Hi, Dr. Kim. Thank you for joining us on the Rotarex KOL Soundbites today. Glad to have you here with us. Before we get started, I would love for you to tell us a little bit about yourself and your practice.
Sure. So I am Billy Kim. I'm a vascular surgeon in Nashville, Tennessee. I'm part of a private practice group called the Surgical Clinic. So it's a multi-specialty surgical group serving the kind of middle Tennessee area. We have vascular surgeons, we have general surgeons, we have plastic surgeons and podiatrists. And we have our service area basically involves multiple different hospital systems, but we also have OBLs within our group as well.
A little bit about your experience with Rotarex and how long you have been using it.
Sure. So approximately maybe 2.5 years, I think now, give or take. So my exposure to the Rotarex has been first through our OBL. In our group, we have 3 OBLs. And so one of our other OBLs, they've been using laser for in-stent stenosis and in-stent occlusions. I wasn't a big laser atherectomy fan, so when Rotarex came around, I was really struggling with what to do with in-stent occlusions, in-stent stenosis, especially in the OBL setting, in patients that wasn't really expecting that, and was really kind of torn with what's the best method to address these problems, not having the laser atherectomy in our center. So when Rotarex came about, it really opened up and kind of changed our practice in terms of dealing with ISRs, being able to open up occluded stents, even occluded bypasses, and being able to kind of treat the patient completely in that one setting versus having to either have to take it to the hospital or have to use a lysis catheter or some sort of other the modalities that wasn't really available. And so having the Rotarex in our system and having in our practice, and I was able to convince our hospital to actually bring Rotarex into our hospital because of the benefits that I saw, having the atherectomy device as well as the percutaneous thrombectomy component of it has really helped my patients a lot.
So you mentioned that you primarily started using Rotarex with ISR. So can you elaborate a little bit how you've kind of expanded or Rotarex has evolved over time with you in the 2.5 years that you've been using it?
Yeah, so originally I just kind of started it as a ISR kind of device. So every atherectomy device that's out there, I really kind of consider it more having a tool in the toolbox. I think certain devices are really beneficial or targeted for specific lesions in the lower extremities. And my predominant atherectomy device has been with the CSI, or I guess now Abbott device. But that has its limitations too. I think its strengths are mainly with calcified lesions. But I was really stuck with what to do with these soft lesions or soft plaque, especially in ISRs. They're usually not, especially if it's kind of a more acute setting, they're not, the intimal hyperplasia is not this calcified lesion. So really excluded the option to use CSI for those devices or for those lesions. So the other devices that we had either were just kind of balloon angioplasty and relining it with a stent, which I really wasn't really too happy about doing. Or the other option would be to try to lyse it, especially for the long occlusion. But that actually had to take the patient to the hospital and then use TPA and have other kind of complications with that. So having to use the Rotarex has really, starting with the ISR, I have started using it for more just native vessels with soft tissue or more soft plaque. But I've also used it for just as a thrombectomy device too, which has been kind of helpful in the arterial space. When we don't have an option to use, when it felt like, I don't need to use like a lysis catheter, something embolized, being able to go in, just kind of suck out a small particle in the distal branches has been helpful.
I'd love for you to talk a little bit about your technique when operating Rotarex.
Yeah, so I've been only using the 6 French most of the time. I'm not really going into the iliacs for these things. So mostly in the SFA popliteal and even the tibial vessels, I've been using the 6 French. From a technique standpoint, I would go in, turn the device on as I'm going antegrade towards the distal portion, but I'll also, have the device on as we go back. One of the tricks that you start using, because I think one of the hard parts is the wire can be pulled back because of how powerful the aspiration component is. So we mark the end of the wire with the torque device that comes with with the wire. So that's like a place marker for me mentally as we're advancing and then retracting the device back to know that our wire is not being pulled away from from where it should be. But in terms of passes, I'll do at least. If you consider a pass once and back, then I would do at least 2 passes. But if you're considering a pass just one direction, like a unilateral direction as 1 pass, I'll probably do 4 passes. Typically, most of the time, and then I'll come out and then rinse it, and then take a picture, do an angioplasty, and if there's still some residual lesion or some stenosis, I may go back and do it again. But without doing a repeat angiogram, I would do 2 full passes, I guess. Once down, and then while still up, going back up, and then come. The Rotarex actually has pretty good aspiration, and it has that component of actually kind of macerating the clot as it aspirates it, which the other thrombectomy devices don't. It's just a mechanical suction. Now, the penumbra, I feel like the Rotarex does a better job of actually kind of, as it spins, the atherectomy component of it, spinning it down, and then just being able to absorb it and aspirate it through the channels. I feel it does a better job and kind of decreases the risk of like the tip of it getting clogged.
So a couple more questions for you. What was it like when your staff to transition to Rotarex?
I think it was a fairly easy transition. I think one of the benefits of it is that there's not like a huge device or machine, kind of like laser atherectomy, that you have to hook up to. There was a little bit of a learning curve using the magnetic device to the catheter and to the drive that's non-sterile. But otherwise, the catheter itself, the wire, it's pretty standard. I think there's a slight learning curve with the staff.
And then what would you tell a physician that has not yet adopted Rotarex into their algorithm?
Oh, that's a good question. So I think that, again, as interventionalists and surgeons and people who are taking care of peripheral vascular disease, whether in the OBL or hospital setting, I think it's very beneficial to have and expand your toolbox. So you'll be coming across different types of lesions, different types of scenarios, included vessels, included stents, stenotic lesions, soft plaque, calcified plaque. And so being familiar with different devices, where the strengths are, and then also knowing which devices work best for which lesions, I think will provide the best results for their patients. So I think adopting Rotarex, I think, has been kind of, at least for me, a game changer. Not having to use laser atherectomy. I just feel like laser doesn't do as good of a job for in-stent occlusions and in-stent stenosis, even though it's indicated. But again, from a laser atherectomy standpoint, I think Rotarex and its indication for in-stent stenosis and in-stent occlusions does a fantastic job. And so I would encourage any interventionalists or surgeons, or vascular surgeons, or anybody who's dealing with endovascular techniques to consider Rotarex as a strong tool in your toolbox, and to kind of be familiar with what the indications are, what type of lesions best suited for it, and be kind of facile with it, so that you again can provide the best optimal care for your patients.
Okay, lastly, tell me about your favorite Rotarex case.
My favorite Rotarex case? Oh, okay. So it was a patient that had a vein bypass graft placed. That bypass actually went down, and he was about to lose his leg. So I ended up kind of relining the whole bypass with a Supera stent. It was a small graft, and it did well for about 3 years. And he had sudden onset of like occlusion of that bypass, and this is his only vessel. Like this is like, if this goes down, then he's getting amputation. So um, normally prior to Rotarex, my algorithm would have been to try to lyse the bypass overnight, try to balloon it and see what happens. We were able to open this up with the Rotarex with like 2 passes essentially. Open up the entire AT and the bypass and include the stent. I did end up ballooning and placing a stent at the proximal anastomosis of where that bypass started, like in the mid thigh. But I was able to salvage this guy's leg, and he sends me gifts all the time because his leg is still around. But it's one of those things where it was one of my earlier Rotarex cases, and I was amazed at how cleanly it cleaned out the stent. I mean, there was really nothing left after 2 passes, and even just doing the balloon angioplasty, it was very clean. So I was very impressed with that. It was always very satisfying, but also just kind of showed how powerful the atherectomy component was, because I didn't embolize anything either. It's one vessel down to the foot.
All right. Thanks, Dr. Kim. It was really great hearing your experience with Rotarex. We appreciate you taking the time to join us today and look forward to speaking with you again soon.
All right. Appreciate it. Thank you. Thank you for the opportunity.